It's pretty striking when you hear that cystic fibrosis. Well, it's not just some incredibly rare condition, it's actually the most common inherited disease in white populations.
Yeah, it's quite prevalent.
And just thinking about that, how one tiny glitch in the genetic code can cause such widespread effects, really something.
It is.
So today, let's really get into cystic fibrosis, try and distill the essentials.
Sounds good. So cystic fibrosis, or CF, it really boils down to a genetic issue. It's autosomal recessive.
Okay, so that means both parents need to pass on a faulty gene copy.
Exactly, a faulty copy of the CFTR gene specifically. It's found on chromosome 7. And well, this gene is super important. It's the blueprint for a protein that works as a chloride channel.
A chloride channel, like a gatekeeper for salt and water in cells.
Precisely. And when that CFTR protein doesn't work right, often because of that common delta F508 mutation, though there are others, the whole system gets disrupted.
Right, the balance is off, and that leads to the thick mucus.
That's the hallmark, yes. Thick, sticky mucus. And it's not just, annoying. It causes major problems.
In the lungs, I assume.
Definitely in the lungs. It gums up the works, makes it hard for those tiny little sweepers to clear things out. So you get this environment where bacteria can just thrive.
Leading to infections and inflammation constantly.
Yeah, recurrent lung infections, chronic inflammation. It's a vicious cycle.
And I remember reading, it's not just the lungs affected, is it?
No, not at all. That same thick mucus can block up ducts in other places, like the pancreas.
Ah, okay, so pancreatic ducts are blocked.
Then digestive enzymes can't get to the intestines where they're needed. This leads to malabsorption. People can eat well but not get the nutrients. That causes poor growth and those characteristic greasy stools.
It's fascinating, really, how one protein fault spreads out like this.
It really is. And think about the sweat glands, too. The faulty CFTR means less salt gets reabsorbed.
So, more salt stays in the sweat, leading to that salty skin.
Exactly. It's a classic sign. The memory tips, salty skin, think CF is really useful. And back in the lungs, it's not just the mucus. The body's inflammatory response, especially with neutrophils rushing in, can actually cause more damage over time while trying to help.
Okay, so thinking about who gets CF, what are the main factors?
Well, because it's genetic, the biggest factor is having parents who are both carriers of that faulty CFTR gene.
Right. Family history is key.
Absolutely. And we see it most often in Caucasian populations. Here in the UK, the incidence is roughly 1 in 2,500 to 3,000 births.
And prevalence?
Around 1 in 3,000 to 4,000 Caucasians. It's important to remember being a carrier doesn't mean you have CF, just that you could pass the gene on.
Got it. So what are the symptoms that might make someone initially suspect CF?
Clinically, you often see respiratory signs first. Things like a persistent cough that just won't go away, lots of chest infections, maybe wheezing, shortness of breath.
And digestive issues, too.
Yes, definitely. Poor weight gain, even with a good appetite, is a big one. Those greasy stools we mentioned. And of course, that salty skin parents might notice.
Anything else? Maybe later on.
Later, yeah, you might see more frequent bowel movements. Male infertility is actually quite common in CF. Sometimes delayed puberty can be a sign too.
And when a doctor examines someone, are there specific physical signs they look for?
There are. Finger clubbing, where the fingertips widen and round out, that suggests chronic lung issues.
Okay.
Then there's often a productive cough, bringing up thick, sometimes greenish or yellowish, sputum. Listening to the chest, you might hear crackles or wheezes, often in the upper lobes.
And lung function.
Spirometry tests usually show an obstructive pattern. Difficulty breathing out quickly, basically. FEV1 is often reduced. But it's crucial to know newborns might seem perfectly healthy initially.
Which is why newborn screening is so important, right? How does the actual diagnosis work?
Yeah, screening is key. It usually starts with that heel prick test looking for high IRT levels, immunoreactive trypsinogen.
And if that's high?
Then they'll likely do genetic testing for the common CF mutations. But the gold standard, the definitive test, is the sweat chloride test.
Measuring the salt in sweat?
Exactly. If the chloride level is consistently high, over 60 millimoles per liter on 2 separate tests, that's diagnostic for CF, genetic testing confirms the specific mutations involved.
Are there other tests used alongside those?
Oh yes. Lung function tests, like measuring that FEV1 regularly, track progression. Chest x-rays or CT scans can show lung changes like bronchiectasis or infection.
And sputum tests?
Sputum cultures are vital to see which bacteria are present, like Pseudomonas or Staph aureus, so treatment can be targeted. And depending on symptoms, tests for pancreatic function or GI imaging might be needed. Even sinus x-rays often show characteristic cloudiness.
Okay, so once someone has a CF diagnosis, what's the management plan like?
It's really a lifelong team effort. A multidisciplinary approach is essential. The goals are basically symptom control, preventing complications getting worse, and maintaining the best possible quality of life.
What are the main strategies involved?
The big ones are airway clearance techniques, physically getting that mucus out, inhaled medications, enzyme therapy for digestion, good nutrition support, and antibiotics for infections.
Plus ongoing care.
Absolutely. Regular monitoring, making sure vaccinations are up to date, and really crucial psychological support for the person and their family.
Can you give us some concrete examples, like airway clearance? What does that involve?
Sure. That often means daily chest physiotherapy, sometimes using devices like vests or flutter devices. Special breathing exercises help too, and regular physical exercise is strongly recommended.
And medication.
Regular sputum samples guide antibiotic use. Some people take prophylactic antibiotics, say for Staph aureus. If Pseudomonas becomes chronic, there are specific eradication protocols. Then there are inhaled meds.
Like what?
Nebulized antibiotics, things like clindamycin or tobramycin. Also Dornase alpha, that's a mucolytic. It helps thin the mucus. Remember, mucus is thick. Dornase alpha will do the trick. And hypertonic saline can help hydrate airways too.
Makes sense. And for the digestive side?
Pancreatic enzyme replacement therapy, or PARROT, is key for most. Capsules taken with every meal and snack.
To help absorb food properly.
Exactly. And because absorption can still be tough, a high-calorie, high-protein diet is usually needed. Sometimes, if weight gain is really difficult, supplemental feeding through a tube, like a gastrostomy, might be necessary.
Are there other complications to manage?
Yes, things like CF-related liver disease might need medication like ursodeoxycholic acid. CF-related diabetes needs insulin. Reproductive health needs careful management. And bone health, watching for osteoporosis, is important too. Plus, addressing any psychological issues is vital. It's a lot to manage, hence the regular follow-ups with the specialist team.
It sounds like a very involved condition. How has the outlook, the prognosis, changed over time?
Dramatically, actually. It's still a serious lifelong condition, no doubt, and lung disease remains the biggest challenge. But thanks to early diagnoses like the newborn screening and all these treatments we've discussed,
Life expectancy is much better.
much, much better than it was decades ago. People are living longer, fuller lives. Lung transplantation is also an option for some with severe lung damage, though factors like gender and socioeconomic status can, unfortunately, still play a role in outcomes.
And despite better management, complications can still occur.
Yes, vigilance is key. Respiratory issues like worsening bronchiectasis or respiratory failure can happen. Digestive problems like malnutrition or liver disease need monitoring. And those other issues, diabetes, bone disease, infertility, they all need proactive management.
Okay, so if we were to boil it down, what are the absolute key takeaways about cystic fibrosis for someone listening?
I'd say, remember, it's genetic, caused by that faulty CFTR protein. This leads to thick, sticky mucus, primarily hitting the lungs and the digestive system. Think. Thick mucus, faulty CFTR, lungs and gut are bitter.
Right.
But also remember that early diagnosis and a really comprehensive team-based management approach have massively improved things.
And looking forward, what's on the horizon? Is there hope for even better treatments?
Absolutely. There's a huge amount of research going on, especially into gene therapies and these newer modulator drugs that try to fix the underlying problem with the CFTR protein itself. That's where the real excitement is, offering genuine hope for transforming lives even further.
That's great to hear. And for anyone wanting to cement this knowledge or revise other key medical topics, you can check out pastthemensra.com and free emsra.com.